People watching now,
Okay.
and that'll grow.
All right.
And then
Hello.
watch it later.
I'm Kelly with Progressive Medical, and thank you for tuning in today. Progressive Medical is a respiratory sleep specialty company here in Carlsbad, and we specialize in the ALS patient and neuromuscular breathing issues. So today I brought some equipment, and I'm going to talk about issues with breathing associated with ALS. I did hand out a slide presentation, and I'll go ahead and give one to you to go along with this. Do you want to keep those at the back when people walk in? Maybe you could give them to them. Thank you, Keith. Here you go. Yeah, that's for me.
You can put it down.
Oh, I can put it down?
Yeah.
Oh, okay. Anyone? Do I have to turn it off? There you go. Thank you. Okay, so we're going to go ahead and start. Okay, the first slide is ALS is a neuromuscular disease. It is not a lung disease, which some people are confused about that. So it's not a lung disease like COPD or asthma. It is a neuromuscular disease, but there are associated or can be associated breathing issues. It's a motor neuron disease, and it affects adults between the ages of 40 and 70. It varies per patient and clinical patterns, so not everybody needs the exact same equipment. There are certain pieces that I brought, 3 of them, to share with you today. That most people do progress to because it is a progressive neuromuscular disease. It causes progressive muscle weakness and atrophy, results in loss of respiratory muscle strength, and death is mainly caused from respiratory failure. So some of the pieces of equipment that I'm going to show you are champions in trying to keep you healthier longer on what if you use these pieces of equipment. More patients with ALS consider it a chronic disability. Dramatic improvement in the treatment of respiratory failure is accomplished with the use of the MPPV, non-invasive positive pressure ventilation. Some people call them a ventilator. Assisted cough to remove secretions. These are all things that help with staying off the progression of the symptoms. It doesn't stop the disease, but it can assist you with the symptoms associated. ALS, and I'm getting the scary slides out of the way first. We call it the triple threat with a diagnosis of ALS. It impairs the inspiratory muscles, causing hypoventilation or shallow breathing. It impairs the expiratory muscles, resulting in a poor cough and difficulty removing secretions. It impairs the bulbar muscles responsible for pharyngeal and glottal upper airway function, causing dysphagia, swallowing, difficulty swallowing, and poor articulation. So speech is affected. So the symptoms of poor ventilation. As a neuromuscular disease progresses, the ability to move sufficient amounts of air in and out of the lungs becomes reduced due to the loss of accessory muscles. And your symptoms may include fatigue, disturbed sleep, the need to sleep sitting up, extra difficulty with night breathing due to the fact that you lay down and then if your diaphragm is compromised, and usually that does become associated with the diagnosis. That is when you realize you're having issues with your breathing when you sleep. Also, morning headaches, which is a sign of increased CO2, which is the gas that we exhale or expel during exhalation. And in high levels, that becomes toxic to our body, causing the headache. Quiet speech with fewer words per breath. Weakened voice. ineffective cough, heightened anxiety, loss of appetite, and weight loss. The first evidence of respiratory muscle weakness in ALS usually occurs at night for the reasons that I just explained to you. When you lay down, your breathing is affected. And particularly during rapid eye movement sleep, because that's when we're not able to easily awaken, because that's when you get your dream sleep, your best sleep. That's when you're resting, relaxed. It's more equivalent to shutting down your computer by going through the steps instead of just crashing your computer and turning it off. And that's what happens when you have ALS and you try to lay down to go to sleep, get into rapid eye movement. It's like crashing your computer. The intercostal accessories and muscles are flaccid during REM sleep. Laying down to sleep puts a weak diaphragm at a disadvantage. Any questions from anyone right now? At any time during the presentation, if you do have a question, feel free to raise your hand and ask me if there's anything that you're actually looking. Okay, you have a question. What is it?
Intercostal muscles are flaccid during sleep.
Intercostal muscles are in here, and when you're in rapid eye movement, everything is relaxed, flaccid, and not rigid or able to work properly. So, diaphragm is compromised. I can't say it's not working, but it's compromised when you're in REM sleep or lying flat. So I'm on the slide that says sleep and neuromuscular diseases. So in order to support the non-functional muscles, non-invasive ventilation is required. So everything that I just talked to you about is treated by the use of the proper therapy, which is NPPV, non-invasive positive pressure ventilation. An inspiration and exhalation pressure along with a backup rate, which means that it's giving you an inspiratory and an expiratory pressure prescribed by your doctor. And the backup rate is a number also prescribed by your doctor that tells us how many breaths per minute you're going to receive if you don't take them automatically. And that is what an NPPV does. And the lack of breath causes the oxygen levels to drop in some and carbon dioxide to rise. Non-invasive ventilation is required to help exchange the gases. So again, when all of these factors happen, if you are using an MPPV, it is able to blow out the CO2 so that it minimizes the negative effects or symptoms that you're getting by not having the appropriate therapy to assist you when your diaphragm or intercostals aren't working properly. Why is appropriate therapy important? Because, believe it or not, being on the wrong type of therapy can be damaging to your health. Being prescribed the wrong pressures can cause the patient to throw central apneas or cause their current condition to worsen. So central apneas are where your body isn't actually trying to take a breath. And I know you've probably heard a lot about sleep apnea. Sleep apnea, and a lot of times, you see those commercials where the husband's snoring or the wife is snoring, and, with centrals, there's not always a snore associated. There might be some obstructive events, but with a central, we call that dead in the bed. You're just laying there, and you're not initiating. You're not trying to take a breath. So that's where the NPPV comes in, because you have an inspiratory breath rate set, and if you don't take that breath, the machine's going to give it to you. So improves your patient's quality of life. I know that, and I did bring the equipment at the back, and we're going to spend most of the time talking about the equipment because I want to know, one, do you have questions about it if you have it? If you don't have it, I want to alleviate some of the fear associated with it because it is your friend. It is going to help you. It's going to improve your quality of life. These are all the reasons why Progressive Medical is in the specialty respiratory business because we know the benefits of being on the proper therapy. CPAP would not be the proper therapy for a patient diagnosed with ALS, even if you were on CPAP before your diagnosis for maybe obstructive sleep apnea. You're going to need the MPPV instead, and the MPPV does accomplish the same thing that the CPAP does, but more extensively because that's what your needs are going to require. It improves your survival. Initiated early, MPPV can prolong survival for several additional years of life. ALS patients can elect to continue assisted ventilation via tracheostomy later if you need to, and can survive for 10 to 15 years more. A trach, yes.
So Kelly, before we go down that path, can we go back to the CPAP again? Some people have described as a CPAP works in one direction, and the BiPAP works in both directions. Is that pretty accurate?
Correct. And that is my next slide, Keith. You're right on track. Thank you for that segue. The next slide talks about CPAP, which is continuous airway positive pressure. Difference being MPPV, non-invasive positive pressure ventilation, is more of a bi level of air. So it provides an inspiratory, like we breathe. When you breathe in, that's your inspiratory, and then an expiratory when you exhale. So that there's two pressures set by this machine and a backup rate. So I know everybody's probably heard of CPAP and BiPAP. BiPAP differs because when you don't initiate a breath, you need the backup rate. And that is what the MPPV provides for you. So if you're on a CPAP prior to your diagnosis, you cannot use a CPAP to treat the problems associated with ALS breathing effectively. It can make them worse because you're not blowing off that CO2, that poisonous gas that we need to exhale. That CO2 can build up. Then you'll start waking up with headaches, vivid dreams. These are symptoms that your CO2 is building up and your therapy is not working effectively. And if that ever happens when you're on an MPPV at the pressures prescribed by the doctor, talk to your DME provider, and that's what Progressive Medical is. We're a durable medical equipment provider. And tell the respiratory therapist, I'm waking up with vivid dreams, I'm waking up with headaches. These are significant symptoms that you need to relay to your care provider so that we can then in turn get a hold of the doctor and say, okay, can we get a pressure change? Because your needs are going to change, and that's really important to make sure that you stay in contact with the clinician. And we can talk to the doctor, or you can tell your doctor. But we are there for you 24 hours a day. Progressive Medical's on call 24 hours a day, so that if you have an issue, a question, you can actually call us in the middle of the night and say, you know what, I'm having difficulty breathing. I've been meaning to tell my doctor at the appointments, but I keep forgetting. So that we're going to make that note. We're going to get a hold of the doctor for you. We're going to get that ball rolling so that we make sure we have you on the right settings. Yes, Keith.
Can you go over again the indications of potential need for adjustment or the therapy in the first place?
Right.
What do we experience, like, in the morning? Can you just go that list one more time?
Sure, yeah. What you'll experience is when you lay down at night or even during the day to take a nap, you're going to find that you feel like you're not getting enough breaths, or you're having a difficult time breathing where it's uneasy and you want to sit up because you breathe better when you're sitting up or standing. You're going to feel fatigued during the day, like man, I don't feel like I got a good night's sleep, because you didn't. You're not getting adequate air exchange. So some of the other things would be loss of appetite, where your voice gets weak, in the morning, waking up with a headache, or having nightmares, vivid nightmares. I've heard some of my patients describe them as like they see a very like colorful, electrified dreams, and usually they're frightening dreams. And this is the body's response to trying to tell you to wake up, to do, your body is going to do whatever it can to get you to wake up. So these are some of the things that you want to look at. And again, I can't tell you strong enough that if you were on a CPAP and you have a CPAP, and why would you need this other breathing machine? Because you've done fine for years on a CPAP. Things are changing now. With the diagnosis of ALS, you have to change that therapy, because it is a progressive neuromuscular disease. So it isn't going to get better, not yet, not till they find, they do more research, and they are doing that. And we're all praying that that happens soon. But for now, you have to move forward with the thinking of what I need to do is do whatever I can to have a better quality of life and prolong the muscles that I have that are working now. And the therapies I'm talking about do that for you. They help you to be able to create a cough. They help you to breathe properly and correctly so that you are actually getting a good night's sleep. And the one thing, too, to remember, not just a night's sleep, when you're sleeping during the day, because fatigue, along with that goes, let's take a nap. You need to have your therapy on whenever you lay down, whenever you take a nap. During the day, like right now, if one of you were doing this presentation, you would probably at the end of it feel a little short of breath. It's okay to sit down and put your therapy on, because these things are helping your organs to function properly and to maintain them for a longer period of time. So CPAP is continuous positive airway pressure. It should not be used for respiratory muscle weakness and hypoventilation. Hypoventilation is how I described where your CO2 goes up because you're not taking a deep enough breath. It does not provide sufficient respiratory assistance, and it increases the expiratory work of breathing. And we want to minimize that because you're already fatigued. We want you to be able to use what you have and extend that. And that's what the proper therapy does for you. So treatment with non-invasive positive pressure ventilation, it supports the patient's breathing rather than assisting a patient's breathing. Like the bilevel, the MPPV has an inspiratory and expiratory pressure, but it also has breaths per minute, and I did talk about some of this already. I think that I did talk about this slide, so if you need clarification, the slide is treatment with non-invasive positive pressure ventilation. When to start your MPPV. Intervention with MPPV earlier than the current standard of care may result in improved quality of life. So when you go to UCSD and they do those breathing tests, like one of them is forced vital capacity, it's called the FVC. And this tells you when is appropriate time for you to start therapy. If your FVC is less than 50%, that's a good time to start on therapy. If your MIP, maximum inspiratory pressure, is less than negative 60, if your PCO2 is 45, and sleep oximetry is 88 for at least 5 minutes. These are all parameters that you would discuss with your respiratory therapist at your doctor's appointment. Can I help you?
Could you just briefly describe the abbreviation? Sorry.
At forced vital capacity
Yeah.
is,
Forced, yeah.
yeah, FVC is forced vital capacity, and that is how adequately you can, blow, 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 blow. You know that test they do where they're going blow, 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 blow. That is your forced vital capacity. So how can you expel? How much of the air can you expel from your lungs? And how long does it take you to do it? How long can you hold that? That's the forced vital capacity.
How long you can hold it?
Well, because when they do that test, they're like, okay, take a deep breath in and then blow, 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 blow. And when you feel like you're out of air, they want you to blow longer because they want to know how much air can you expel? How long can you hold that to get all that air out? Maximum inspiratory pressure
Inspiratory?
is when you're sucking on a straw. That's what they're doing. They're saying, how much air can you inhale? Through a small, they give you a mouthpiece. They liken it to pretend like you're sucking on a thick shake, a really thick shake, and try to see if you can get that up into the lungs. And that's what they're measuring there. PCO2 is the carbon monoxide that we talked about, or carbon dioxide. And sleep oximetry, that is the oxygen level in your blood. And your oxygen level should be at least 88%. And you want to keep it above 88 or greater.
And then you measure that while you're sleeping, or is it just the term sleep oximetry? But
we're talking about sleep oximetry, but some people have a spot checker that they can measure it all the time. And I'm going to say one thing about that.
Okay, thank you.
If you're a person that has a spot check oximetry, I see a lot of patients get obsessed with it. Don't do that. The times that you really need to, if you start feeling some of these symptoms that I've told you, or if you're doing activity, then it's a good time to check it and see how you're doing, because it's a parameter you could share with your clinician.
And it's a different value than this 88% if that spot check?
No, it's the same value.
Same value.
Yeah,
So
same
you
values.
go for 88%
Or more.
Yeah.
Above 88% is better.
So
Okay.
for our web audience and maybe others in the room, what device are we talking about? This $14 or $24 device that CVS people get, or
No, nope. And that's the next thing. Yeah, you don't want to get a cheap oximeter, because, again, you are going to be dependent on it. Even though I said don't get obsessed with it, you will, because you're going to be saying I got to stay at least above 88%, because if I drop below 88%, what's going to happen? Well, you're not going to feel very good. And if you consistently drop before 88, you're going to start really feeling differently. You might see your nail beds and lips turning blue, things like that. You need to get a good oximeter, especially the spot checkers, because most people don't buy a bedside oximeter like we use for doing a sleep study because they're expensive. But there are some good ones out there. But my suggestion is, check on the internet what their what are their ratings, like how many stars do they have, and then check the comments that people put in there. And I will tell you that generally, and I haven't looked recently at Costco, but generally Costco seems to carry a higher brand than other places, because they don't sell it if it doesn't have high ratings. So to me, I'm saying if you're going to pay out of pocket for medical equipment, I'd say personally, this is coming from Kelly Kennedy, not the company I work for, anyone else, you might want to go to Costco, because they do tend to have better brands and they stand by their products. If for some reason you find that it's not working, bring it back and they'll take it back. So I can't really say that about every company out there.
And again, you were saying, you wanted to stay 88 or above.
Right.
And if you don't get obsessed, but if you are below, then you start NVVP, or is it something NPPV or something else?
No, you should do do it before that.
Right.
You don't
right.
want it to drop to 88% or lower.
Okay.
This is I just wanted to give you something to go by, so that you can refer to it
Okay.
when you're talking to a clinician if they haven't explained
I'm sorry, you said we need to increase what?
the settings.
Oh,
on the
settings.
therapy,
Okay,
inspiratory,
settings of the
IE,
therapy. Okay,
inspiratory,
gotcha.
expiratory.
Thank you.
And I do talk about oxygen here too, and I'm wondering if that slide is coming up. Yeah. So.
So Kelly, before you go on,
Uh-huh.
so the three acronyms that we throw around or here is the MIP, MIP, the forced vital capacity, which you have on your side, and then PCF. What's PCF?
PCF. That is a Phil question. PCF, pulmonary. Is it a diagnosis or?
Would this be the three tests they would do at
Uh-huh.
clinic every visit?
Uh-huh.
So I'm
Okay.
just trying to translate CPF into one of yours from the slide.
Right. I don't really know the answer to that question. 'Cause,
Okay, we'll figure it
'cause
out.
I'm in the field, and Phil's in the hospital, so,
Yeah, Paul, Charlie, Frank.
yeah.
So, okay, great. We'll
Okay.
investigate.
So sorry, I can't answer that question. I don't want to give you a wrong answer, so.
No worries.
It's not one of the parameters that we use in the home. I can tell you that. Now, Filiberto Gomez, who is our respiratory manager, works in the hospital, and that might be something that he's more familiar with.
We found that peak cough flow.
Oh, yeah, that's for the cough assist. So that would be, can you produce a cough? And you know,
Strength of it.
right, and it's pretty self-explanatory, because when you try to get a patient to cough and they can't, you'll see more like a, where they're really trying to produce a cough and they can't, leading to secretions and management of secretions. So, and that would lead to the ordering of a cough assist. But most of the time, the doctors will order those before it gets to a serious point, because the patient's having trouble getting rid of secretions or producing a cough so that they can get rid of the secretions.
So Kelly, do you recommend getting the BiPAP or the other device you mentioned, the suction machine and the cough assist all at the same time?
I do. I see that a lot, where once the doctor orders the MPPV, they'll order the suction machine and the cough assist all at the same time, so that the patient is working with all three therapies earlier on in their diagnosis rather than later, and getting familiar with them. Because being on therapy, nobody likes to think of themselves as having to be dependent on a piece of equipment, but really what it's doing is it's increasing your quality of life and making it so that you're able to keep the quality of health that you have longer by using the proper therapy. So the cough assist is probably to me the most invasive therapy that we set up, and it's loud, and so getting on it sooner rather than later is better, because you have a chance to work with it. Because what I see a lot, and it isn't right, it isn't the way to do it, but most of the time when you get all three pieces of equipment set up at one time, it is a good idea to incorporate it into your schedule and start working on them right away. But most of the time, one of those pieces of equipment gets put in the closet for a little while, so the patient wraps their mind around the fact that they're on therapy, they have to use it. But when you need that cough assist, it's better to have tried it, be familiar with it, and so you're able to use it, because it is invasive in the fact that it blows air very forcefully. And most of the time when a patient uses it for the first time, their eyes get real big. And I try to tell them, this what I'm telling you right now, it's very invasive. Don't worry, because it only lasts for 5 seconds between inspiratory, expiratory, and have that suction machine ready, because it is very effective and you will get secretions up. So you use the cough assist with the mask that literally attaches to your face as soon as you put it in the mode for inspiratory, expiratory. But the secretions are going to come up, and you're going to be able to get them out with the suction machine, so have it all ready to go. Because otherwise you're going to end up, trying to deal with those secretions, and you're not prepared, and then, that raises the stress and the anxiety of the patient. So you don't want to do that. You want to minimize the stress and anxiety, improve the quality of life, and get those secretions out. All right, so the MPPV, or bilevel with backup rate, is used to rest the respiratory muscles, prevents sleep-related progression of respiratory failure, and prevents hypoxemia in ALS patients, which is the result of hypoventilation. And that is all regarding the increase of the CO2, not being able to take an adequate breath. This is all the stuff that we want to prevent happening. And that's why those 3 pieces of equipment work well together. Supplemental oxygen warning. I have 2 pages on that. So, common physician response to breathing problems is to prescribe supplemental oxygen, and we call it vitamin O in the healthcare industry. And this may be the worst thing to give a person with ALS or post-polio sequela, because hypoxemia is a symptom of shallow breathing and is not the problem. So the oxygen is going to raise your O2 sats, but if you can't expel the air properly, you don't need supplemental oxygen when you're on therapy. Okay, so when you're using these therapies, you are able to expel all of the air. When you're not, it can cause a situation where you are unable to, because if a weak respiratory muscles cannot be addressed directly, then respiratory assistance should be considered during periods of hypoxemia, not oxygen. So the proper response would be to be on non-invasive positive pressure, not oxygen. Because lots of times, when you go to the emergency room, the first thing they do is put you on oxygen. That's why we call it vitamin O, because, okay, let's get them on oxygen, and then, we're going to assess everything later. A person with neuromuscular disease may experience shallow breathing only at night when he or she is not able to consciously take deep breaths, or is in the supine position. And we talked about this in the very beginning. Positioning is very important. Giving supplemental oxygen may further exacerbate or worsen the problem by reducing the body's natural drive to breathe deep enough to inhale and exhale properly. So that's the problem with oxygen, supplemental oxygen. Giving supplemental oxygen may further worsen the problem by reducing the body's natural drive to breathe deep enough to inhale and exhale properly. On non-invasive positive pressure ventilation, that isn't happening. You are breathing properly because the machine is assisting you. So you wouldn't need the supplemental oxygen. Now that is unless you have asthma, COPD, and other diagnoses along with the ALS. So, and that creates another problem. Improper use of supplemental oxygen may cause one to slow or even stop breathing. Okay.
So the machine, it doesn't increase the oxygen, it just...
No.
Yeah.
Nope, the machine does not. An MPPV does not provide you oxygen. It's only giving you room air. So unless the doctor orders to bleed in O2, and you'll see that because you'll have a whole nother machine associated with it. Yes, Keith?
Yeah, I was just going to ask you, do they, and this little $15 adapter to your NPVV or BiPAP that just brings the oxygen in. The other thing we see in some parts of the country is people prescribed oxygen during the day and their BiPAP therapy overnight. And sometimes the overnight includes oxygen, sometimes it doesn't.
Right.
Just different approaches. And I think the thing we read is that if you have oxygen during the day, for darn sure, you need to use your therapy overnight or you're going to get CO2 buildup, right?
Exactly. Right. So, like oxygen during the day, although there's different chains of thought on that, but if you're going to use it, I mean, we want you to be standing, sitting, not laying down, because everything worsens when you're laying down. But I'm not saying you should or shouldn't use oxygen. I'm saying you should talk to your doctor about it and ask other people that, other patients, that if you see somebody that is on the supplemental, to ask them how it's working for them. If they notice a difference, talk to your doctor, find out.
So in San Diego, there's an easy way to ask other pals. We have a Pals to Pals private email group that ALS Association doesn't be involved with. Muscular dystrophy is just strictly the families to each other. So if they have questions on this kind of thing, they use that network to talk locally. And then, worldwide, there's a website called Patients Like Me, and the subgroup being the ALS group. And sometimes people will float questions or make inquiries there to get information from other families. That one's a little, be aware you're on the internet. There's people on there trying to sell you stuff. Just be aware of where your information's coming from. But good networking.
Okay. Effective cough can be measured by the peak cough flow. When cough falls between 270 liters per minute, it says use upper abdominal thrust quad cough. Use a cough assist. These are two things you can do. Upper abdominal thrust quad cough is a exercise that they can teach you how to do at your doctor's office, or use the cough assist, or both. And the cough assist is that piece of equipment I told you about where it blows a force of air in and exhales one, helping you to move the secretions and expel those secretions effectively. Cough assist machine looks like this. It's also on that table right there. There's two examples.
Which one?
This is the old version of it, and I brought both because usually when a piece of equipment is ordered, we sometimes get an order from ALS to use the inventory they have, and their inventory carries both. So I wanted to show you both. This one is the original cough assist. Settings will be set by the respiratory therapist and shared and instructed to you and the family members, making it hopefully less scary. This smaller one is a portable one, a lot smaller, lighter, with a handle, with a carry bag. So improving your quality of life so that you can take it places to be able to, enjoy games. If that's something you want to do, go to a football game or the kids' sports, grandkids, so that you can get out of the house, because really quality of life is what it's all about.
But you use it like all the time?
This one has a battery option as well. No, you only use it intermittently or when needed. Okay?
You don't want to be caught somewhere needing it and wishing you had it.
Right.
It's kind of a...
I was just wondering, why would you carry it?
And you would probably,
But it's just...
well, like if you want to go on vacation.
Right.
And like, let's say your grandson is a semi-pro or a pro athlete. We've had this happen where they wanted to travel to Hawaii to go to the Holiday Bowl. And in order to do that, you're going to need it because you're going to be gone for an extended period of time. And again, the smaller one has a battery option, the larger one does not. So definitely the travel one would be the one you'd want to use.
Is there much danger with pneumothorax?
Can you repeat the question for the webcast?
Is there much danger of a pneumothorax with this machine? Yeah. Not if you're diagnosed with all of your conditions taken into consideration when they order it. So I have been doing this for a long time. And I've never had a patient ever had a problem with that. So, but it is one of the side effects that they do list in the manufacturer guidelines. So you definitely would want to tell your doctor if you've had, pulmonary embolism in the past or anything that would warrant being suspicious of a pneumothorax. But I don't think that I would never tell my patients, be careful because there's a high risk. I wouldn't call it a high risk. Okay, so when you have, if you're not able, like when MPPV is no longer effective, and this would be later on in therapy. Yes?
So before we go on, how often should I get a respiratory exam for my MIP and my forced vital capacity? And what would you recommend? Or do you have a physician?
Well, usually it's not us recommending it. It would be the ALS clinic at UCSD or your doctor's office that you use, and they're going to put you on a timeline. But I think they check those at least twice a year, right? Every 6 months. So, or as needed, because if something changes, then you have to relate that to your doctor to tell them, something doesn't feel right, because this can be your first chance at making sure that if you don't have the right therapy, we add it before it's critical. Okay?
So for those who aren't accessing the clinic environment, nationwide we see a lot of variety on how often respiratory tests are done. I think the most common is about every 3 months. Getting one early, of course, is helpful to establish a baseline. And then depending on your rate of progression, your frequency may be increased or decreased based on necessity. Some clinics actually try and do that monthly. Very rare, but we are aware of some that try to do monthly exams. Okay.
So the last couple slides are the sad part where when MPPV is no longer effective and you're not able to tolerate the MPPV because of bulbar impairment, and that's where the swallowing and speech is affected, then now we usually tend to have them talk to their care practitioners about other options and decision making, because at that point, that is when they talk about having a trach or opting not to. Again, earlier in the slides, we talked about our trach patients doing very well when they choose that option, and when that time comes and they can't use the MPPV without having a trach. So I think I've seen a switch to choosing to have a trach rather than not, because again, it can actually support your breathing for an additional 10 to 15 years in some cases. So, it's something that I think you should do research about. I'm a big proponent of, if you're ever going to make a decision for you, again, read up on what is going on, and make sure that you don't just go on the internet and read these horror stories, because anybody can post anything they want on the internet. No, I'm just kidding. But the thing is that you have to make an informed decision that's right for you. And there are, with the trach, there are issues with you have to make sure that you maintain a very clean, sterile environment, and you have to commit to making sure that everybody that you come in contact with has that same goal in mind, because you don't want to get an infection, increases the risk of infection. But 10 to 15 years, that's a pretty good outcome to be able to increase your life with a progressive neuromuscular disease. And with good care, they report that they are satisfied with their quality of life and would make the same decision again. And this is in regards to ALS patients that elect a tracheostomy with ventilation, because once we bypass this bulbar where the issue is, and then we get a trach, now your MPPV is going to work the same, if not better, than it did before. So other choices would be hospice or palliative care, which is a group of people that your doctor would get you in contact with so that it's more of a end-of-life choice, having your advanced directives in place. And I know that you've had someone come and speak about all that. It's something you do need to think about. And do you have any questions? Because now I wanted to kind of talk about the other two pieces of equipment there, which is a ventilator and a suction machine. And I don't have any handouts for that. So remember I told you the three pieces of equipment, and that would be the ventilator, or MPPV, non-invasive positive pressure ventilator. Take them up to the front. Okay. Can you carry it? Okay. All right. So this right here is, this one is a trilogy. There are different manufacturers, of course, of the ventilators and the cough assist, but this one is a trilogy, and this is one of the most common ventilators. And this came from the ALS closet, and that's why I brought it, because again, you're probably going to be more familiar with the equipment that the ALS has in their inventory and that you see other patients using. So this takes the place of a BiPAP or a CPAP. So this is the non-invasive ventilation, and it usually is used with a full face mask, but you can use a smaller mask. We have a over the nose mask. We have just a mask that goes over the mouth, and then we have nasal pillows that are very small. The thing is, with this therapy at night, I personally think that the full face mask is a benefit, because when you're using a mask that doesn't cover the mouth, if your mouth falls open during the night, then the air is going straight out and you're not getting adequate therapy. And then again, the appropriate therapy is the goal. So I do, however, feel when you're using it during the day, using it with a nasal mask is good, so that if you have visitors and you want to talk to them, it allows you to be able to do that. I don't recommend having therapy on if you're trying to eat, because of the choke precaution. But, a full face mask at night is a good therapy. You're going to be able to get adequate ventilation, and the trick is going to be getting a good mask fit, because if you have leaks, if it's not a closed system, then you have issues with the therapy. But that is something that Progressive Medical will work with you on, because we're experts in mask fitting and making sure that you have a good seal. Yes?
So as a user of one of these pieces of equipment, how can I wake up in the morning and know how I did last night?
Well, if you were a person that experienced headaches and they're gone, that would be one indicator. If you have a partner and they tell you that you snored, that's not a good sign. That means that we probably need to change the mask. Like I said, if you breathe through your mouth, then we need to give you a mask that allows you to do that, because you can, but you have to have the right mask for that. If you feel fatigued, if you wake up and you just feel like gosh, we had a whole night's sleep and I feel like I could go back to sleep, then something with your therapy needs to change, either your pressures or your mask. But your partner usually is a good indicator because they'll tell you. If you find that you're falling asleep during the day, that's another indicator. Am I forgetting anything, Keith? Did you have anything in mind?
Well, I was going to take you to the next generation of equipment that you can actually hit a button and get a sleep report on your screen.
Oh, yeah.
And then if you sign up, they'll electronically Wi-Fi that.
Right.
And the provider can give you a summary week by month. And they have little happy faces or frowns. Did you have a lot of leaking? Did you have
Right.
events? The technology is pretty advanced now. And then when she talked earlier about getting a hold of your respiratory team and they need to make adjustments, oftentimes they can do that via Wi-Fi. So the pulmonologist calls up your records, agrees a pressure change is needed, sends it right to the machine electronically. So it's really making some
Right,
big
and that's going to be
advances.
happening more and more because,
Can you look at that report yourself and
Oh, right.
get an idea?
Right on the screen.
Right, but it's actually like, in English.
Yeah.
you can understand what it's
You
what
can
it's saying
understand
to you,
what
yeah.
it says, how
There's-
well you slept,
yes.
or some percent.
Especially on
don't know
the
what-
one that comes on your phone.
Yeah.
Now, there are other reports that are more clinical that we can get from, and those are usually used for the doctor, so that the doctor can fine tune and dial into what is going on with you.
But there are some numbers in the report that you should be able to, either like a percentage that you slept overnight,
Right.
or hours, or
Right.
minutes, or
Yes, and how many events you had, and how long did those events last, and
What's an event?
event is where you either had a decrease in your oxygen level, hypopnea, or you stop breathing altogether. It will even tell you what kind of an event it was. Was it an obstructive or was it a central? Which is what I talked about earlier, where you don't initiate a breath. You're just laying there. There's no even attempt to initiate a breath, to breathe that in and out. With obstructive sleep apnea, your partner will usually report, they were gasping and choking, and, or if you happen to wake up gasping and choking, that would be an indicator for you that you may be having some central events, or even it could be a sign of obstructive.
An example of that can be if you're using this therapy and the power goes out and you don't have a backup system, you can wake up in a real panic because your whole situation just changed. And so they actually have apps for your smartphones, and the data goes there, and it's really is.
I have an app for my sleep, but not connected with mask.
Right.
Right.
Even just with the sleep apnea, maybe not associated with the ALS, is that the
same equipment? Just curious.
What was your question?
If the people have a sleep apnea not associated with this diagnosis, is that the same machine or is this a different machine?
Well, no, it depends on what their sleep apnea diagnosis
Okay.
is. Like, is it obstructive sleep apnea or is it central sleep apnea? Because anytime it's central, which is usually the same associated with ALS, you do need a backup rate. So those
You do need
people,
what? Oh,
the
backup.
backup rate.
Oh, okay.
Mhm. So it gives you a breath if you don't initiate one. Those people would be on either a BiPAP ST or an MPPV.
Okay.
And this machine has a battery, okay? So that means if the power goes out, it's going to still work,
Kicks in.
right? There are some bi-levels that, that have that capability, but not usually included from your provider or your insurance doesn't pay for it. So
Yeah, which is a problem.
it is a problem,
Yeah.
and it's very important that you have that. It's because you need it. So that's one of the benefits of utilizing the MPPV with your diagnosis, because it is warranted and the insurance will pay for it. So keeping that in mind whenever you're dealing with, oh, I have a CPAP in the closet. It's not the appropriate therapy, but also it's a benefit for you because you have a battery paid for. So if you have a natural disaster, if the power goes out, you're good. Your machine's going to keep blowing air. You're never going to know until that battery gets depleted. But it's going to tell you way before it's depleted. They'll start alarming that you need to wake up and look at the machine. This is a suction machine. This is a portable suction machine. And what that does is it helps you to expel the secretions. Again, very important to have this when you have a cough assist because you're going to need it to be able to get those secretions out of there quickly. I brought a hard yank hour. That's for mouth suctioning, okay, which is usually what we start out doing. Trach suctioning would be a soft catheter, but that would come after you make that decision to be on to have a trach, and that's more intensive. Most of the time, the patients are with a yank hour, and it's just to bring, because the machine brings the suctions up to the throat, and then you just go in and gently remove it. You don't push this down your throat. You just get it to where you can go on the sides and expel it. And this again has a battery so that you can take it with you to a game. And some people will go to the bathroom to do the suctioning. Others just pull it out right there. And at a game, nobody would probably know because it's so noisy. So those are the 4 pieces of equipment that I brought. Any questions? Yes, Keith?
So how does air travel affect individuals who are receiving this therapy?
Well, you do need to check with your provider if they're going to allow you to bring the equipment on the plane. If you're dealing with oxygen, it's gotten very difficult to fly with oxygen, and they usually want to provide you with their own oxygen. And so if you're going to, I guess the first thing I need to say is when you're going to travel, plan way ahead. Because I've had it happen where a patient called 3 months before they want to go travel. And you would think that should be enough time, but I've had it happen where they didn't have an answer from the airline, and they already bought the ticket, they're ready to go. So you really have to plan, I'd say 6 months in advance before you're going to go on a trip, because you need to make sure that they don't want, because sometimes they want, first of all, they're going to need a prescription. And when you travel with it, you always should carry your prescriptions with you, even if it's a CPAP machine. Whether, whatever therapy you're on, you need to bring your prescriptions with you. Any supporting documentation, put it in the bottom of your bag. Better to be safe than sorry.
And that's for someone just using the therapy at night?
Yes.
With no oxygen, it's still a real hassle with the airlines? Okay.
It is, because anytime there's a battery involved, if you hear them talk about, the FAA regulations, it's because those batteries tend to get hot. And sometimes if they're not handled correctly, they can explode. And they don't want anything that can be used as an explosive on a plane. So 9/11 really changed everything for traveling because, unfortunately, they kind of have to think like someone that's devious and maybe not really using the therapy for the right reason. They're just trying to get something on board a plane. So everything they do is with your security in mind.
So you still can travel. I don't want to make it,
Yeah.
but just plan ahead. And
You can definitely travel.
So we got one question ahead of you, and then we'll be right there.
Yes.
Go ahead.
I just traveled to Hawaii, and it was relatively simple. United Airlines and Hawaiian. They required a 12 hours of battery backup or 12 hours total battery. They required your doctor make out a form, which is fairly standard, and sign it that you are on 2 liters, 3 liters, or whatever. And you simply carry those things. And we were only asked once, I think by Hawaiian, to see the form.
Right.
But the form is online, and it seems like the FAA goes along with this. And the airline supplies nothing, but I will say, for the first time ever, I asked for wheelchair support, and they were wonderful.
Good.
They really met me at the threshold, and I even talked them into giving one to my wife when we had a long one.
Good.
So I found it not all that hard and doable.
Great. And that was
Terrific.
United?
That's a 5-hour flight.
Right.
So
And that's United Airline that you
that
flew?
was United.
Right, and Hawaiian. I
And
heard you
Hawaiian.
mention them. That's great.
Good news.
Because we want to see more of that happening rather than making it harder for you to travel. It also depends on, how long of a flight it was and whether it's in the United States or if it's travel abroad. So those are things to take in.
Might have been other problems.
But I think that's awesome. Thank you for that story because I like to hear stories like that rather than that it was you had a hard time.
And I was concerned about whether I would need to up my oxygen flow,
Right.
and I really didn't. I monitored it with a non-Costco, but it seemed
Yeah.
pretty good. Although it broke.
Well, I'm
easily.
not. I don't work for Costco. I don't have stock in Costco.
We
Just saying.
agree about Costco.
Yeah,
Right.
right.
Yeah.
But anyway, I even tried at 1 below because I was afraid, that I might run out or might need to go to 4 or something like that. And on my standard therapy, and I don't know what they pressurized to. I thought it was 5,000 or 6,000, and I'm planning to go to Tahoe next in a few weeks at 7,200 feet. I may come down quickly, but I don't know. I'm planning
Right.
to.
Well, at least you're trying, and that's
Yeah.
good. But you're right. You do have to take in altitudes with your oxygen use. If you're on oxygen, you
Right.
have to factor that in. And
Yeah, but it didn't seem to require me to take any more.
good. That's great.
Excellent.
And is that what you brought with you? That oxygen? Yeah.
If you're outside of the insurance system, what are your options as far as getting this equipment? I mean,
If you're paying cash.
paying
Is that what you're
cash.
saying? With a doctor's prescription, it is required. All of these pieces of equipment require a doctor's prescription, whether you're in insurance or paying cash. You have unlimited possibilities. There's lots of different manufacturers, that make the same pieces of equipment, and all of them have different specifications and targeting different patient base. So your options significantly increase if you're paying cash and you're not using insurance. When you use insurance, those choices are pretty much insurance driven. So it changes everything.
So, from a non-insured individual with an ALS diagnosis, the ALS Association Loan Clot will provide a BiPAP, cough assist, and suction machine for a 60-day period. If your situation is such that your insurance scenario is not going to change, then we'll continue to let you to use the equipment, but we'd have to help you find funding for the monthly supplies after 60 days. Okay, but we're not going to come pick up the equipment at 60 days, day number 61, and take it back. But we just have to work with you or that family on the monthly supplies required. And can you talk about that? The hoses, the masks, the nose pillows, the replacement cycle for all of that, right?
Okay.
That would be the monthly supplies I'm talking about.
Right. Insurance allows certain time periods for changing equipment. Full face mask is every 6 months. The nasal masks, they will change those pillows every 3 months. But the headgear, they won't. You have to keep the same headgear and frame and just change out the pillows. There is cleaning involved with all the equipment, and it's just a matter of soap and water and rinsing it, and we suggest you do that weekly. It's the same for the suction equipment. There is the tubing that was on the cough assist is the same that we use for the, for the ventilator we use a circuit, but it's the same tubing. It's just it's a disposable circuit, and that is, we give you 2 at setup, and then usually every month you get another one to switch out, so you have 3, a supply of 3 going ongoing, so that if anything happens to the circuit, you have a backup. And the circuit is the tubing used for the ventilator. Okay. The cough assist, there's the tubing that I showed you, and that also is the tubing that would be used for CPAP as well, but I'm only telling you that because you're probably familiar in your lifetime with CPAP and not so familiar with the cough assist or the ventilator. And that tubing, again, should be washed on the weekly schedule and then replaced monthly.
And then for my first setup, I don't know if I want a full face mask, a partial, nasal. What are my options in the first 30 days? Or how does all that work? So I pick a mask and a week later it's terrible for me. What do I do?
Progressive Medical, I can only speak with what Progressive Medical does. We will do a mask fit at the time of the setup. And first of all, we have to look at the prescription that the doctor wrote, because sometimes the doctor will write for a specific mask, or whether it be a full face, nasal, or pillows. So first and foremost, we have to follow those guidelines because that's required by the federal government. That being said, you have the option of a full face, a nasal, or an in-nose mask. Based on what the patient tells us, if you are a mouth breather, you're going to get a full face mask, at least for at night. We usually give 2 masks at setup so that you have a backup, and that you maybe have 1 mask for sleeping and then 1 for during the day, so that if you are using it during the day, it gives you more options to be able to communicate and to be able to not have the point of contact always be the same. Changing the point of contact on your face is important, because otherwise you could get skin breakdown from using it so much. We want to try to not get skin breakdown. We want to minimize it. But again, something being on your face, pressing. That's why it's really important to choose a mask that's very soft and flexible. And the new generation of masks are more designed to literally float on your face rather than cinch it down real tight. Because what I see is a lot of patients, when we do our setup, we'll tell our patients, okay, so this is 30 years of experience mask fitting. Take my advice and don't cinch down your mask. But for some reason, most people will cinch down their mask thinking that tighter is better. It isn't. Tighter causes leaks and skin breakdown. So it's better to have at least be able to fit 2 fingers under the mask straps, which is this, and not cinch it down too tight. When you put your mask on and off, always start with your mask on, because especially with a ventilator, that will affect how quickly it gets to your correct pressures. If you have the mask off, you turn the ventilator on, first of all, you're going to get an alarm, and it's going to take your machine longer to realize that you're hooked up to it. It's not an issue that you're not breathing, and and the pressure is going to be harder for you to breathe on, which isn't your prescribed settings, but it's a machine trying to catch up with the fact that there was air blowing, it was free flow, and wants to make sure you know it's not connected. So start by putting your mask on and then hitting your on button, and do that quickly. Don't put your mask on and sit there, talking to someone without your therapy on, because that's not good. That'll build up your CO2.
And the newer machines have the auto start
Right.
and auto shut off. So you can't put your mask on and you don't have to touch anything.
Right.
It detects and it waits for you to fall asleep and adjusts therapy accordingly. Some machines have a, what do they call
Right.
that, a ramp up?
Yeah, ramp.
Yeah.
Uh-huh.
It's pretty
And
pretty
auto
amazing
track,
how these have
things
changed
like
in the
that.
last, yeah.
If it's set, because if it has that option, it needs to be set by the clinician. And, that's, again, depending on your doctor. Some doctors don't want a ramp for the patients, and they'll say no ramp. Not usually. Usually now they're very familiar with using a ramp and auto track, and so it's a comfort measure, so they're more inclined to go ahead and let the clinician have the leeway to choose whether or not the patient decides they want to use a ramp or not. And a ramp is where we can set the pressure, the initial pressure startup, lower than the actual pressure, so that if, as you fall asleep, it's down at a lower pressure, allowing you to fall asleep at a more comfortable pressure, and then gradually increases to the prescribed pressure. Most of our machines, though, are auto titrating, and so the ramp kind of is going away, where the machine is always in a very comfortable setting because it senses when you're awake and when you're asleep, and then it just gradually increases as you need it, when you need it. And a ramp gradually increases whether you need it or not to the prescribed pressures. So that's one of the benefits of the new evolving technology these days, is they're really fine-tuning the comfort for the patient, which that's all good because it improves your quality of life.
And your partner.
Right.
20
And your
years ago,
partner.
these machines like a vacuum, somebody's running a fan or something. Now
Right.
they're whisper quiet.
It's true. They are. And what's funny is most spouses or partners will tell you when you're the clinician talking to them about how's the therapy going. I don't really hear the machine because they've gotten quieter and they're lower pressures. And, so that took some getting used to because they're used to listening to the hum of the machine, that it's their friend. They know if they hear that their partner is doing well. But now the machines are so quiet that they sometimes are you still breathing? It takes them a little while to trust the new technology so that they're able to sleep better because, when one person has a sleep disorder, most likely the partner has one too. Either it's because of the noise from the snoring, or they're so in tune to their partner's breathing that they're constantly hitting them. You're snoring, breathe. You're not breathing. So
We're snoring, we're not breathing?
no, if either you're not breathing and they're tapping you to breathe, or you're snoring and they're tapping you to turn over and change your position. So
Because they can't sleep.
they can't sleep. Yeah.
Yeah, no, you mentioned somewhere if the snoring, then maybe you're not breathing properly, then you use face masks. So I was wondering if snoring is an indicator. of
Snoring
some
can be an
issue.
indicator of hypopneas. Where your airway is decreasing the level of air that you're getting. Like you're not, like when we're up walking around breathing, you're breathing fine. You're not snoring. But when everything starts relaxing, then sometimes they start closing off things like the diaphragm's not working properly, or your tonsils may get in the way of your airway. So snoring can be an indicator of a hypopnea where you're getting less air.
If you were a snorer before ALS, and then you ended up with full mask, should you not snore?
Yeah.
Even
you
if
should.
you're a snorer beforehand?
Oh, yeah. You should not be snoring. If you're snoring with therapy, you need to talk to your clinician because we need to do something differently. And sometimes it can be as simple as the mask is leaking. There's not a good seal. And sometimes it means we need to change the pressures or change to a different mask.
One final question, anyone? Okay.
Okay. Well, thank you. And hopefully that this has been informative and alleviated some of the fears around the equipment. So have a great day.
So we have a special guest from UCSD.
Hello, everyone. My name is Danielle Bussey. I'm a study coordinator doing clinical research. If you've met Dr. Avitz, I'm his study coordinator. So I'm here to talk about some of the clinical research options you have, some of the clinical trials that are going on currently at UCSD. We have one non-therapeutic trial and one therapeutic trial. So the non-therapeutic, which is open to all ALS patients, is CREATE. It's a data symposium, so basically what happens is you come in for 5 in-person visits, and we do respiratory assessments. You see a neurologist who does some neuromuscular assessments. We do a couple questionnaires. There's a cognitive questionnaire called ECAS, the ALS-FRS, which is a function scale, which you guys have probably done in clinic a couple times. That one's just to collect data. You give blood work. One of the perks of this study is that you get genetic testing done. The first visit, in-person visit, we draw blood, and that it takes about 6 months, I think, to get your genetic results back. So that's something that can be a huge expense to get done on your own. So you get this done for free. And then you also get to see a neurologist and a study coordinator, so you get a couple more respiratory results, just more contact, which is nice. What will happen first, if you guys are interested, I have some flyers in the back, is a screening visit. So that's just a telephone visit. That's just to make a pedigree, collect some medical information, any medications you're taking, just some basic foundational information, and then when you come in, we'll do more of the assessments. The second trial we have is Mallinckrodt. It's HP Athcar gel. It's a steroid. With the drug therapies, there's more inclusion and exclusion criteria. So some of the big ones is a respiratory function of above 60%, which is, it's a huge problem for a lot of ALS patients. Also symptom onset within 2 years. Negative hepatitis result, negative HPV. You cannot be on the BiPAP continuously throughout the night. You cannot be a diabetic. So those are just some exclusion criteria, just to get that out there. Before I tell you more about the trial, it's a 9-month trial. So what's happening is you'll come in for screening baseline. We'll rule out all criteria that could exclude you, and then you'll start dosing. So with dosing, a nurse comes in, shows you how to do an injection. It's a self-injection subcutaneously daily. And the steroid, it's phase 2, so now they've ruled out major side effects, ruling out that it's dangerous, and now it's saying, is this effective? So we're in phase 2. I think they're hoping to get 213 patients. UCSD is trying to get 10. We've currently screened 1, so we're seeing if it will slow progression. That's what it's testing. There are 2 drugs, of course, Radicava and Riazol. I think Riazol is 20% slowing progression. That's the average. And then I think Radicava is 30%. That's what they're saying. And of course, this isn't saying if you take it, you're going to see a 30% progression. This is saying with the population that it was approved of. I think it was somewhere in Asia. It got approved. And Japan, yep. And with that population, it was seen to show 30% slowing progression with some patients. So you could also donate through UCSD has a biospecimen collection. So I don't know if you guys have met Gil. He heads that. So you can give blood. And if the time comes and you guys make that decision to possibly donate cerebral spinal fluid or your brain, that's an option offered through UCSD too. And of course, that's a personal decision, and you would most likely go through the clinic, and Gil can set that up for you. So, question for me?
The gel one you said is the daily, and for the 9-month every day?
Every day.
Okay.
And of course, if there's any these studies, you opt in, and if yes, I'm sorry.
And would you come during that time to see doctor as well? Or?
So you come every month. So there will be 12 in-person visits for that during that 9-month period. It's about every month you'll be in contact. You'll have to come to UCSD and do that.
You would not be taking those other 2 medications at 20%?
No, you cannot take Radicava. You can take Rhizol. Rhizol, you need to be on it for 4 weeks on a stable dose. The stable dose is 50 milligrams twice a day, I believe. So, but Radicava is not allowed during the study. Any other questions for me? Okay. Yes, Keith.
So if I'm interested in clinical studies and I want to be aware of what's available nationwide or worldwide, what do I do? And then how do I get connected? Electronically.
So you can go onto a website called clinicaltrials.gov. What you'll do is you'll type in some information, mainly your diagnosis, and it provides you with a list of trials that are currently going on. The first thing I would say before you click on the trial, click on the list it gives you, first thing you want to do is scroll all the way down and look at exclusion and inclusion criteria before you get your hopes up and you see there's a drug. That'll rule out a lot of trials for you. That'll rule out some trials for you. It'll make it easier for the search. A lot of what you want to look for mainly is symptom onset. I know it's about 2 to 3 years on average. A respiratory result is usually on there. But some of them have extended rates. Some of the drugs have, I think I saw one recently that was about 6 years symptom onset. And then what you also want to do is they'll list the information of who to contact. You want to ask, the first thing you want to ask is there any major side effects with this treatment? That should be your first question right off the bat. What's been the result of this? So you can go on there. Also, there's a website called ALS Untangled. It's Dr. Bedlack. He's done a lot of research in ALS. What he does is you go on and there's a list of clinical trials that people are interested in and you can vote on it. So if one of these trials gets a certain number of votes, his team then researches that drug or that therapy or whatever theory is out there that is said to help ALS. So that's another option, just to get some research tested that you're interested in. So, yeah.
Center for Disease Control Registry?
Yes, RDCRN. So that goes along with the clinicaltrials.gov. So that'll also link you to clinical trials that are going on, anything that can really get you contact and help. Yes.
For this gel that you were describing, just in general, even clinical studies, do they do first on the animals trials and then on humans? Or?
Yes. So phase 1 has already occurred. That's a small subgroup of people, and that's really testing, are we seeing any, life-threatening side effects. So phase 1 is completed for this. This is phase 2. So now this is efficacy. So does it work? Or are we seeing any slowing in progression? What is it working, basically?
Well, the reason even like that gel went into phase 1 was it tested on animals, on, rats or something, and they've seen actually improvements there.
HP Athcar gel is currently approved by the FDA for lupus treatment.
Okay.
and also for rheumatoid arthritis. So it's being used for those two things. It's been FDA approved.
And they saw something like, oh, maybe it will help also with ALS.
It's a steroid. Yes, there's of course a maybe. That's what's being tested. There's no result as of now that's saying, hey, this is slowing progression or this is working. This is even on. I only know about the phase 1. So the phase 1 would be there's no major side effects. So I can't tell you that it's going to work on humans because just to make it wouldn't be ethically correct. So 230.
I was just curious, any clinical study, I'm not in the medical field myself, so I was just wondering if the clinical study always, first you do the testing on animals, you see something, and then you start on the people with phase 1, and so forth. Or is it just, like you're saying, it was treatment for some other diseases, and then they said, okay, well, maybe that looks like we could use for humans, so there's no animal study at all of it. They didn't see any result for an animal study.
I would have to get back to you on that. I can definitely look that up for you and get back a better answer for you. But I know it's not, there's no major side effects. That's the answer I can give you right now, but I can definitely get that answer for you.
And be careful. We'll get the animal rights people.
I know.
We're here in San Diego, okay, right? And you know that's a good balance. I mean, we need that too. So thank you all for attending and our webcast viewers. The webcast is recorded, so people can watch it again later, or those who couldn't watch it this time. A big thank you to Life Pro Financial Services providing this awesome venue for our support group meetings, and the technology. James and his team are just wonderful. And big shout out to Papa John's, who has provided us with some light refreshments. So we thank them for pizza. And with that, this concludes our monthly Care Services support group meeting. James? So please, there's water, there's water.